name is Carlene Ketela, and I'm the Chief Executive Officer at Michigan Academy of Family Physicians. Our program today, Navigating and Surviving How to Manage Patient Care During a Time of Crisis, is presented as a member benefit from the Michigan Academy of Family Physicians. In response to the horrific violence that took place on the Michigan State University campus this February, MAFP wanted to provide members across the state with helpful, practical resources. It is my pleasure to introduce Dr. Rachel Clamo. Dr. Clamo serves on the MAFP Board of Directors and currently practices family medicine in Oxford, Michigan. Welcome, Dr. Clamo.
Thank you, Carlene. I really want to thank you for the opportunity to present the material today. And as those slides are coming up, I'll just give a brief introduction. As Carlene eloquently pointed out, we're presenting this material today, unfortunately, because for family physicians, appreciating what the experience of working, perhaps also working and living in a community that experiences an extreme crisis, and in particular, a violent crisis, something akin to a shooting, where we've seen many examples of in school and academic environments. It's an area where physicians are potentially now going to be challenged to have to exist, to operate their practice, to take care of their patients, to take care of themselves. And so this presentation is designed to share my experience as the only physician in the medical office on the day of the shooting in Oxford. And with the recent shooting at MSU, provides us an opportunity to share this material again. As you know, I'm a family physician. My practice is currently in Oxford, Michigan. And at the time of the shooting event, I was serving as chief of family medicine at the hospital where I also practice, which is in Rochester. And so we can advance the slide. I have no financial or other conflicts to disclose other than I did share with you where my work environments are. So there's three main objectives for the presentation today, and I hope that at the end of this presentation, you will have increased knowledge of how to balance both patient mental and physical well-being with your own well-being as a physician, in particular at a time of crisis, such as a school shooting, that you will have had the opportunity potentially with this material to be able to discuss skill sets that female physicians, but other physicians as well, of course, have opportunities to act in the role of leaders in a time of crisis, and that you will have gained perspective on the unique challenges that come with events like this, and that there are also potential rewards in being in those leadership positions, both within your medical office and potentially beyond. So November 30th, 2021, around 12:51 in the afternoon in Oxford, Michigan. This is a story, similar has been shared across our country when shootings occur. But the story that I'm telling today is my story of my experience and what my office experienced the day of the shooting that occurred at the high school in our community. Our office is merely a few miles from the school. So we experienced just a very obviously an abrupt interruption in our day, staff members' phones starting to go off. Many of our staff members had children or other close family members who were students in the building at the time. So you can imagine the immense pressure of being in a position of operating a practice where you're trying to help patients and having this kind of event occur for you and your staff. So there was a lot of messaging going on, a lot of texting, people starting to become extremely upset, worried, a lot of tears starting to happen. We were right before the turn of the hour where we would be getting into the afternoon's patient schedule. So Patients are starting to come for the afternoon, many of which didn't realize yet what had happened. A lot of sirens, just sirens and sirens and more sirens and more sirens. And so I'm sure you can imagine there was a prolonged period of shock and crisis in our work environment. Each person dealt with the situation differently, depending on if they had a child in the building or if they did not, but obviously had close relationships to the other staff members. There were folks who obviously were not able to function in their job roles, folks who coped by praying, folks who, dealt by taking action to move things forward, which was the role that I played in the situation. So we can go ahead and move forward to the next slide. So really in that first hour, it seemed like days compressed into an hour. But as you think about what that experience might be like to be in the midst of an absolute terror crisis where people are fearing for their lives of their children, who are part of your staff, that first hour is a critical period of time. And these steps and items are things that I experienced in looking back on how I dealt with the situation. So within that first hour, it's very important that a leader must be defined. There must be a single person who is going to direct the action. It just so happened on that day that our office manager was not on site. So really, it put me in the position of having to take charge. So that single leader must be defined. And my feeling is that the physician will be the default leader in that situation and should be. There was immediate need for crisis intervention for the staff, just providing all types of support, physical, emotional, mental health care directly to staff. Just again, physically being there for them, hugging them if they wanted that, praying with them if they wanted that, just letting them know that they could let us know what they needed, because each person deals with these things differently. You're immediately trying to figure out, okay, what resources do we have, because we have a whole afternoon of patients. So who can see these patients? Who is capable of seeing these patients? It happened that on that day, our nurse practitioner, it was either her out of office day or she might have had some other things happening, so she was at home. And we were able to divert patients off of one of the staff members who had a child in the building, off of her schedule, to this other person who was actually at home. There needed to be, again, division of personnel to meet people's individual needs and start to begin to plan for patient care for the afternoon. One also must realize that everyone is fearful. Is there a risk to us? Is there a safety risk to us? So you're immediately, until you know otherwise, making sure that the office is secure, making sure that everyone is up to date on the situation, using as much factual information as possible, ensuring that doors are secure, entrances are secure, so that everyone feels as comfortable as they can be in the work environment. It is difficult to get accurate information when things like that are going on. Everyone is on their different social media. People start to, go to the news. So we were really looking to try to get as accurate of information as we could from legitimate sources once those were available. In terms of notifications, then from that point, we needed to start to notify folks about what had happened for our office and how we were going to strategize going forward. Just needed to send information to let the other physician who wasn't in the office that day and the other clinicians not there, what was happening and the fact that we were going to need to make arrangements going forward. There was a checking and rechecking process with people when they are going through an extreme emotional crisis like this. So I would just keep circling back to people to make sure that they were physically okay, and emotionally doing okay, because as new things would happen, how they felt might change. And those things could change minute to minute based on information they had. And we can go to the next slide. So then we moved officially into the afternoon. So at that point, we were starting to see that both clinicians and staff who had students in the building were able to reconnect with those folks. So some staff actually left to retrieve their students from the Meyer parking lot. Some students actually who had been part of the event at the school then were back in our office with us for a period of time. We were getting staff who were directly impacted. So if a staff member had a child in the building or a very close family member, we were making arrangements for them to finish their day at home and not continue to work, because that is really not appropriate to do when you've been through something like that. We were making very quick decisions on patient care. So a decision tree of, who is mentally and physically able to deliver care at this time, who feels that they can do that. We also needed to look at what front office and back office support would be available, because as you know, our offices, we work as teams. So you need to have people in different roles in order to deliver the care in a reasonable way and support reasonable patient care flow. And then of course, there needs to be a modification to the existing schedule. There is just no way, obviously, to see everybody on the schedule that you would have seen given the impact on the office. So we made changes such that those that were directly impacted, those clinicians were scheduled with other folks. So the nurse practitioner who wasn't in the office that day, and then I took on a number of patients so that those who were directly impacted could go home. We also canceled later in the day visits that were preventive in nature. So well child exams, preventive exams such as physicals, Medicare annual wellness visits. Just made an executive decision that those were not going to occur on that day and be rescheduled. And we were only going to focus on urgent needs, acutely ill patients, people who had an acute issue that needed to be addressed that day, and that everything else would be on a pause and be rescheduled. And then made a determination that in terms of all of the different boxes we have of results to go through, cases to be addressed, calls to be answered, that the idea was only things that were absolutely critical to be responded to would be responded to. Everything else would wait until folks felt more mentally and physically able to do those things. And then a big part of the physician leader's role in this situation is to notify leadership outside of the office. Now, every practice is different. A private practice is not necessarily going to have all the resources and people to notify that I had. But if it's a practice that has administration outside of the office, there's a lot of notifications that need to happen in order to move forward. So as the day wrapped up, we now move into the evening phase. And so the next step that I took was to begin some leadership calls. So you have to decide, okay, who needs to know about this? Who needs to know what our needs are? Who needs to be involved at this point? Because you can't just go back to business as usual. These kind of events are traumatic for the people involved, and steps need to be taken to acknowledge and help those involved. So in terms of the leadership calls initially, I was in contact with the other physician in the practice and our office manager to begin strategizing how we would move forward in terms of clinical care over the next several days, as well as additional support. It's really important to be clear about who's responsible for what, because duplicating work is not going to be a good use of your time. So focusing on teamwork and being very clear who was going to do what things was an important step in being organized through this process. Next day clinical planning occurred in those discussions. So again, day after, who is mentally and physically able to deliver care. And also, same as you were in the immediate phase, what front and back office support are able to support those who will be delivering the care. And then you're thinking next phase, what about the rest of the week? Who is able to deliver the care for the rest of the week, and what will be the support available? Again, depending on how directly people were impacted, some people may need more time off to focus on their family or address their own personal needs. So just a very open discussion about people feeling ready to be back in the work environment, not only in those first hours, the very next day had to be addressed, and then again the rest of the week. And then the final phase really was the crisis and trauma intervention planning phase. And that was a large part of the role that I played in this situation. And I would break this down into two phases, the early stages, and then what I refer to in quotes as the email. We can go to the next slide. So the email. So it's very important to communicate clearly about the situation and what you need to help you move forward for the office. So it took a bit of time, but I authored an email that was reasonably long in length, but I made sure it was extremely clear to communicate how I felt we would need support to move forward after this crisis. So you have to ask yourself, who does this email go to? Who does it need to be, who needs to be included? So the physicians and clinicians within the office setting, the office manager, then there may be layers of administrative support. So you may have a practice director, and then there may be regional physician and administrative leaders that need to be aware of what's going on and what content needs to go into this email. So what I believe should go into this email is first, a brief summary of the crisis, what happened, because if they weren't there, they don't know. So they need to understand what occurred in the office that day, what people went through in general, give them an idea about what happened in the office, give an impact statement essentially, and then a brief summary of how that is currently impacting the practice in terms of, you know, what we have lined up, and our resources, and where we think we're going to need support. And then also a brief summary of what you've already put into place, meaning, you know, what have you done with schedules? What have you done locally to help move forward? And then probably the most important part would be the specifically outlined asks for the leadership and other support people. You have to clearly ask for what you need, because if you don't, you're less likely to get it. You have to explain to people what you feel you need, what your practice needs. As a physician, you are uniquely able to know what is needed. Your training, all that you have been through, allows you to have the skill set and knowledge to be able to make these asks. And you have to do that in order to get the support you need. It's not just going to drop over. You have to specifically request it and reach out to get that support, especially in the immediate phase. And then you have to also be very clear about what timeline you think you're going to need resources. So I believe, I said that I thought that we were going to need intense support over the next several days, but that I felt we would need many weeks of some degree of additional support for the practice. The other thing that I specifically asked in my email, the second point there, is that I specifically said to anticipate a backlog of administrative tasks for staff members, that we were going to get behind, that charts might not be turned over as quickly, that things may be coming into boxes and not get out of them as quickly as possible, and to anticipate that based on what we had been through. We'll go to the next slide. So we move now into the first day after the office shooting occurred. I'm sorry, not the office shooting, but the shooting occurred at the high school, and our first day back in office after the shooting, which I refer to as the day after. So we did modify schedules to accommodate directly impacted staff. They either just were not in office or had much more limited schedules to give them the break that they needed to transition. We had some communication from the physician leadership in the office, myself, through the office manager and to the staff, what our plan was, for the day, how we were gonna run things, what our goals and objectives were. And we really continued to do very local check-ins, just checking in with people on how they were doing, just being very aware of everyone. We normally, a day-to-day basis, everyone does their own work and stays very focused on their work, but more interaction on the day after, checking in and just seeing how people were doing and feeling. And if you saw someone looking like they needed more support, trying to help them where you could. And we also communicated what we had generally asked for in terms of support and what the timeline would look like. That hadn't been completely determined and rolled out yet, but to let people know that I had, on behalf of our office, asked for a tremendous amount of support from our greater organization, and that those things would be happening soon. And then there were quite a number of emails in follow-up with leadership to solidify the plans for the support that I had asked for, just getting the right people involved and getting people kind of signed up to come and be the support that we need in the office. And so really now we move into what I would consider the crisis recovery phase, which would be the first few weeks after the crisis occurred, after the shooting. So we had a formal crisis debrief in our office. It looked somewhat like this. We were in our kitchen area, and we formally sat down to debrief from the experience that we had on the day of the shooting. Schedules were blocked to allow participation without pressure. Although I will say, as much as you try to plan in a family medicine office to protect people's time, it's not always easy to do. I think you understand that, because patient needs are not always predictable. But I think we managed to get everyone the ability to participate. We also needed to acknowledge that people had a varying degree of comfort with this sort of a formal debrief. Some people have never done something like this before. Some people are really not comfortable sharing or being open about what happened. But I think what we have learned from emergency department settings and in hospital settings, when there is a trauma that occurs, a very difficult case, having a debrief and having people with experience participate in those things are a very important part of allowing clinicians to address their personal needs, and start to recover through the process. The leaders of these sorts of debriefs need to be skilled. They need to have experience with facilitating and moderating um, a get together like this due to the high level of emotion and sensitivity involved. So I had asked for a number of different types of folks to be involved from behavioral health. So we had chaplains as part of our debrief. We had a number of counselors as part of our debrief. And we had membership from some of the behavioral health leadership team within our larger organization. And each type of clinical person brings their own professional experience to the debrief. And it's really, really important to have those folks involved, because you don't want to just sit down and rehash what happened. You want to have support be occurring while this is happening, have people be able to share their experiences and where they're at, but to really have trained professionals be participating with you. Again, there needs to be a physician leader in this setting. Physicians, again, have unique skill sets. The length of our training, the experiences we gain as residents and in our careers lend us naturally to stepping into roles of being leaders. And so I found that I was serving as a moderator and a monitor of what was going on. And I think my physician colleagues would be doing the same as well. You have to make sure that the conversation is moving forward. If you're sensing people being uncomfortable, you're really having a constant radar on the group to make sure that it's occurring in a way that you hope will ultimately be positive. Those behavioral health chaplain and counselor supports brought a lot of physical handouts and different resources to share with our office. There were opportunities for individuals to make requests for services and support. What I shared with leadership was that a lot of what's being done right now in terms of well-being relies a lot upon online resources, applications, etc. And in a situation like this, when people's hearts are torn apart, when people are under extreme pressure, when people are emotionally just in a state they never thought they would be in, dealing with a situation that they never thought they would be in, those sorts of support things just are really not appropriate. Nothing can replace the personal touch, the one-on-one connection, the physical contact with someone that provides a different level of personalized care. And so I was very clear about the need for humans to be with us, to support us through this process. And so staff were able to make requests for services and support and become more connected. A lot of contact information was shared between the different chaplains, counselors, and behavioral health folks, so that we had direct cell phones or emails for people when you're feeling under pressure and stress. Searching for the way to contact someone is not going to help. So really making those contacts easier was part of the process. And finally, making it very clear that this was a very open door situation, that we hope that people will feel comfortable and be honest asking for support and sharing how they're feeling with absolutely no sense of judgment was very, very important. And the crisis recovery then extended out of those first few weeks then into the first month after the shooting. So as we think about the situation for clinical staff, I was able to secure an on-site chaplain or counselor in our office. In that first week or so, we had someone there almost the entire time we were open. And And that started then to decrease as we moved forward. This allowed for scheduled opportunities for walk-in counseling for staff. And we did make an effort to support each other to allow people to take a break from their clinical work and go in and actually have a counseling session on site. And I think this was absolutely not only necessary, but to me is the gold standard for how support should be offered for an office setting when something like this happens. It is not possible for people to maintain their work life full time, but also take a ton of time to drive somewhere to go seek counseling. Bringing those resources right to the people in need is what made the biggest difference, and I think allowed people to participate because the barriers were taken down. The counselors, chaplains, etc., were basically making our common area their home. And whenever anyone felt that they were ready or had some time, they would basically go in and say, let's do it. And we secured a few of our patient rooms to be used for on-site counseling for staff. And that, I think, was very effective, and a large number of staff, including myself, took advantage of that on a number of occasions. There were additional handouts and additional resources that got brought in, again, as it became more clear where our struggles were as a team. There were some visits from leadership. I think that does allow staff to be visible and to let people know who have the ability to control things bigger picture about the impact of an event like that on them personally as an employee and the impact that it has on their work environment. So it is good. It can feel awkward to have sometimes people from leadership there who you don't interact with on any kind of a day-to-day basis typically. But I think the advantage of that is to take that opportunity to tell people how you're feeling and what's going on and what's happening for you, because you're charged with taking care of the patients that the greater organization serves. So they need to understand as much as they can the situation that you and your staff are experiencing. And then we had some team-based support at what I would refer to as reminder times. So you can imagine the actual shooting is only the first trauma. And then you're going to be reminded of that day with every funeral procession, every memorial service, every court appearance, and every legal update. So with each of these different events, it's part of the healing and recovery process, but it reopens wounds at the same time. So Oxford is a small town, generally speaking. So the funeral processions proceeded right down the main street in front of our office. We gathered as a group to watch as many of these as we could, just to be together and support each other through the process. And it was difficult, but I think part of the way we took steps to recover from our experience. Additionally, in the crisis recovery phase in that first month, we are now thinking about our own patients. So our patients, like many practices, serve a broad area. People will drive far for a really high quality family physician. However, many of our patients live in our community. And so now not only are we affected, but our patients obviously are affected and have a greater amount of need. So what I also asked for in my original requests was not only enhanced behavioral health support for our office, but for our patients. So I specifically requested that we have our larger organization resources more available in our office to be available for interactions with our patients as it was needed. So we did have counselors and chaplains available, such that we could offer walk-in consultation. This was very low pressure. There was no, taking of names and taking of cards and everything. It was very casual, such that, if it came up, we were able to offer, hey, we've got a counselor here. Would you like to do it? Because what will happen is patients will come into the office because they had a regularly scheduled visit for their hypertension, diabetes, bipolar disorder, you name it, and then break down partway through the visit, discussing the shooting in the community. So to be able to have those resources available in the office as a support was immensely helpful. In general, there was a great increase in demand for behavioral health visits, just on the broader scale, as I'm sure you can imagine. This need was coming from students who were patients of our office, who were in the high school at the time, but also the middle schoolers and all those in the community and in the greater area. When a shooting happens in one academic environment, there's a ricochet effect in other environments as well, in terms of how people are feeling. So there was a large amount of impact. We were seeing increased demand from a behavioral health perspective from the parents of the affected students and any students who were currently having their education at the high school. Different staff members in the community and general community members. We were having discussions with people who were retired, but just were beyond emotionally affected and needing help after the shooting. We did give the option to have longer slots for the behavioral health visits during that period of time, because you can't rush a patient in crisis. You can't rush through those discussions. They need to have the time to share. So during that period of time, we did extend the time of those visits, more in the 20 to 30 minute range as needed, to provide what support was needed. And we made a priority referrals for behavioral health visits and the referrals that patients needed, meaning that we arranged to have a notification system with our health system's behavioral health service that if an Oxford patient, if a patient of our office needed to get into counseling, that we were able to put a priority on those, such that red tape was eliminated and those patients had access to virtual visits or in-person visits quicker than a patient otherwise would have. And then you will realize that your family medicine office becomes a community resource, becomes a place of refuge, as it probably is even outside of a crisis like that. It's where lonely people come to spend time and talk and such, but that expands in a time like this. So you will find that you are, again, serving as a professional resource within the community, a referral resource to other services. We did have the larger organization provide us with some additional brochures and support resources that dealt with trauma specifically, because that's not something that we typically just keep around. So it's something to think about, though, to be able to identify what brochures or support resources on trauma, or specifically recovering after a shooting, might be available that you might want to use. So it was very helpful to have those brought to us. And the crisis recovery, again, continues beyond the hours and days and weeks and months, but then globally into that first year. So for clinical staff at that point, there was a 1-month follow-up debrief that occurred somewhat in the same vein as our initial crisis debrief happened. We reassessed what the needs were of everyone in the office. We talked about what educational needs there were to meet the needs of our patients. So we will discuss a little more later that medical problems start after a shooting like this, and not everyone may feel completely up to date dealing with the very large variety of needs that may arise. So trying to think about where we might have to provide some additional education or resources to help the clinicians meet the needs of patients at that time. There were regular check-ins at just again, more of these ongoing reminder times, because these processes are very long. So there's more court proceedings that occur and everything. Many of these things are streamable and available to see. So with different stages of court proceedings, that often would bring up emotion. There were events within the community. There were vigils and other events that occurred in the community, and always checking in with people after all those things occurred, I think is very helpful. There was a lot of discussion about civil lawsuits, and people have a lot of emotion about that process. And that just became another point of check-in when news breaks about something. People are going to have feelings and emotion around how everyone is dealing with things legally. In terms of school board and school processes, it was affecting our patients because the education was transitioned to virtual care or in virtual learning. Therefore, it was impacting the success of students and just the educational process. So that does then impact the way that you interact with young people who are students in your offices. They're going to be dealing with different issues when their education is completely uprooted into a virtual setting, much in the way that things happened during COVID. And then, of course, there are commonly subsequent threats to school environments, and there were a series of follow-up threats and things that occurred. And you can imagine every time something like that happens, stream of text messages from high school students to staff member parents about things going on. And I don't think I need to explain to you that that causes a lot of anxiety and a lot of emotion for clinical folks when those things continue to happen. And then you ultimately get to the 1-year anniversary of the crisis, experience that 1-year mark from the shooting. Obviously, it was very notable. Recognition, was given generally in the community to that and within the school. But again, unless you make a conscious effort to figure out how you as a team and an office are going to recognize that 1-year anniversary, it's not going to just happen necessarily on its own. So thinking about planning ahead, are there people who don't want to work that day? Is there something unique that we're going to do? Are we going to take some additional time together? How does each individual office want to deal with the 1-year anniversary? And then an additional ask that I had to do with crisis and active shooter training and preparedness. So an event like this makes you really think about the security of your own office environment. what resources you have in the environment for safety, what is the knowledge set of the staff about what we do in the event of something like this. I don't think that, at least in my training and generationally, people before me, I don't think that really there really was a lot of training about active shooter environments and how we proceed. But in going through this experience, it really lent to taking a positive step of gaining education, knowledge, and planning around what we would do if there was a shooting or an extreme violent threat within our office setting. And we engaged both health system resources as well as local resources in getting that done. And there was discussion of creating a wellness center or space within our office. In complete honesty, that didn't come to full fruition. But it's something that you can think about, if you are able to, in your office setting, to have an area that's just quieter. There might be a place that someone can just go, whether it's for a few seconds or a few minutes if they needed to deal with something difficult. And also in that first year for our patients, we are continuing to see, and you will continue to see, a massive uptake in visits that are centered around behavioral health topics. Family physicians deliver the absolute lion's share of behavioral health in this country. However, after a shooting, that is going to escalate to extreme proportions, as I'm sure you can understand. You're going to have different types of visits. You're going to have visits with what I refer to as direct witness students, students who actually saw the shooter, people who actually saw people experience effects of the violence itself. You're going to have visits with very close friends of the deceased or injured. You're going to have visits with siblings and parents of people who were in the school environment. You're also going to have visits just with students who that's the place they went to school thinking they were going to have the experience they anticipated, but their experience now has been forever changed. And then you're going to have visits with teachers, staff, board members. When you're a community family medicine practice, you see everybody. So you're going to engage with all these different types of folks, and then community members as well, who are impacted. There's going to be home and life work impacts. So with a shooting like this, it has a impact impact on the actual physical plant of the building. And the building needs to, after the criminal piece is done, needs to have repairs and things done at the school. So that's going to impact staff schedules in terms of, again, whether their kids are at home and who's now taking care of the kids and supervising them, etc. And then again, bringing up the impact for patients in terms of the 1-year anniversary when that comes up and how that directly impacts things for your patients. And then additionally, impacts on your practice. There will be an acute need to have as much comfort as you can with an extremely wide array of behavioral health topics. In order to do this well, as you know, you need to be able to make a proper diagnosis. You need to be familiar with treatment options and have a comfort with the scope of practice that allows you to do that, meaning that you're going to need to know who your referral resources are to help with the things that you can't do on your own. There will be the need to differentiate between psychological and organic diagnoses in these situations. And you do this on a daily basis, but that's going to be heightened. And so that piece of your practice will be further challenged. You will need to have sensitivity and be able to identify high school students impacted. So this is a really important point, that when patients present themselves, it's very important to make sure everyone who interacts with them just has that awareness. So we would say, this is an Oxford high school student, this is someone who was in the building, so that we're just sensitive to that, and then can think about what degree we're going to ask them about it, or ask them questions about help they need. But again, just being very sensitive to the trauma that they've been through. So we would make some notations just in the notes, just to remind each other about if they were high school students that were impacted. And then one of the biggest challenges is maintaining, as best you can, well-being for yourself as a physician throughout this process. I think this is a major topic right now for family physicians and physicians in general, due to a lot of pressures. However, when something like this occurs, it just adds a new dimension that you will have never had experience with necessarily before. And being able to do the best you can to be as well as you can through the process is going to be a big issue for you. And so next, I'd like to talk about the types of problems that you're going to likely see after a community crisis, such as a shooting in a school or other environment. And so this is just a summary in chart form of some of the diagnoses that you are going to see. And I present it in this way to really give honor to just the massive spectrum of behavioral health topics that family physicians ideally have large charge of in order to best serve their patients. So I'm going to just read through these just to, again, make the point: acute stress disorders and reactions, post-traumatic stress disorder after they've been through the acute phase, acute anxiety and chronic anxiety. So already, just with other stresses that might be happening in people's lives, there's a lot of chronic anxiety. Now that's compounded with an acute phase. Adjustment disorders, depression, panic disorders, a variety of different types of social phobias, eating disorders, insomnia and other sleeping disorders, nightmares, bedwetting, developmental regressions are common. You're going to see students of ages that had complete capability to manage a lot of different things and regress after an event like this. You're going to see developmental regression in behaviors such as toilet training, bedwetting, just those kind of day-to-day things where young kids were progressing nicely and now have regressed. Learning disorders, so students that are suddenly really struggling academically, a large uptick in students and people in general who are expressing suicidal ideation or even plans for suicide. There's going to be normal and abnormal grieving that you're going to appreciate. Relationship problems, a lot of issues with whether it's a marital relationship, different types of partnerships, familial relationships, just a lot of stress and strain on existing relationships. Generalized behavior problems, kids that already had either full oppositional defiant disorder or other generalized behavioral problems may regress. Certainly attention and concentration disorders um, seem to become a more prevalent issue to deal with at times like this. Generalized phobias, substance use disorders become a larger issue. Unfortunately, people, as you know, are looking for ways to cope. And even as young as middle schoolers and high schoolers, and then adults there beyond, are known to cope with drugs and alcohol. And so more of those types of patient issues will occur. And then there's somatization, so again, you're trying to sort out what's organic, what's not, what is directly connected to the brain, causing a physical issue, or what may be a pure physical issue. And so being that you're in the position of doing what seems like the impossible, managing that whole matrix, you're in a position of taking care of yourself as you are trying to help others. Physician, heal thyself, right? And so these are some suggestions, and they are humbly just based on my experience um, and my experience in the broader picture as a physician over time. So I think the general concept of sharing the load, so not being afraid to delegate, to give work to other people who are capable of doing work if you are feeling like you need more support, to take time away from your practice when you are able. I think we all appreciate the difficulty of taking time away from practice, but that's very important. And when stressors occur, people can tend to say, oh, maybe I shouldn't take that vacation or what have you, but being away from the practice is really important. Keeping in contact with the leadership on expectations and different goals, and being realistic about what can be accomplished and what can't be accomplished when you are yourself focusing on your own well-being. It's important to continue to ask for help without any fear, of apparent weakness in asking for help, because it's very, very important. It's important to be very adaptable in a post-shooting situation, to be flexible with yourself, and allow yourself to feel differently on a daily basis depending on what's happening. You need to lower some of your personal and professional expectations. And I think this is a real struggle for physicians in general. We hold ourselves to very high standards. We're involved in many things oftentimes. We're managing personal lives and professional lives. And frankly, you need to just say, what I'm going to be able to do here is probably going to be less for a while. And that's just going to need to be okay. It's important to share openly when you're ready about the impacts that you've had both personally and professionally. Again, the self-care things, we can sometimes lose track of these things, but getting down to the basics. Are you moving your body? Are you exercising? Are you doing your best to eat things that are healthy for you? If your faith is an important part of your well-being, are you continuing to utilize that as a support? Are you engaging your friends? Are you taking time for your family? Are you doing what you can to reduce stress where able? And I think it's really important to acknowledge these things aren't always easy to do. And so you need to just do the very best that you're able to, and not honestly get down on yourself if you don't think you're giving yourself the best self-care, because doing the best that you can is simply that. It is the best that you can. It's important to engage professional help where needed. You know, in the immediate phase, seeking out those counselors if you do have them in the office, and expanding beyond that if you feel that you need that. And it's important to be reflective, I think, and think about what's been learned through the process, and acknowledge that it was a very, very tough process. And you may at this time be thinking of other ideas that lend themselves to physician well-being. And I think finally, in terms of this material here, important to acknowledge that not everyone in your family or friend circle or even professional circle will have the ability to engage with you and hear your experience and support you in the way that you might think they would be able to. They're just not going to be able to understand your experience because these things are very personal and very unique. And though more and more people may have experience with something like this, many people you engage with really just may not know what to say, what to do, and how to help. So just be aware that you may need to keep looking for the people that you need until you find them. And then a comparative slide to the slide where we talked about just the immense amount of behavioral health needs for the patients in your practice. It's important to remind yourself about how special you are as a physician because of your training, and because of your training, how you have innate leadership skills that allow you to be incredible at a time of crisis. So these are just some of the things that you have. And I think it's important to acknowledge those things and remind yourself that in order to be successful to the point you have, you certainly must have good listening skills. You must be adaptable. You are patient. You have emotional intelligence. You are able to learn things quickly. You're sensitive to situations. You are often the most selfless person in the room. You are organized. You're humble. You're able to prioritize. You're capable of setting goals. You respect yourself and demand that in your interactions with others. You're accountable for your actions. You're ambitious. You care. You have humility. You are able to include others and make them feel comfortable. You have a great deal of knowledge. You're capable of achieving perseverance through difficult situations. You're very resourceful. You're reliable. You have unique qualities to you as an individual. You are vulnerable, however, and that's an important part of your experience. And knowing that despite all of these intense, powerful characteristics, there's a vulnerability to you as well. You have the capability of identifying well-being. You have a great deal of wisdom. You're compassionate. You understand how to connect. And I think family physicians, above all things, they have just an understanding about what's happening for the patient in the room and what's happening in the bigger picture around them. And now as we move to some concluding thoughts today, I just want to remind all of you that, I certainly hope that the vast majority of you will not have the experience that I had. But I think it's important to be prepared and to acknowledge that my experience might be yours at some point in the future. And I hope that through this process that some of these more specific suggestions and experiential notes might just give you a better way to start approaching a situation if my experience were to become yours. So just to remind you that you absolutely have what it takes to be a physician leader, even if it's not something that you've naturally done, you have the training within you to do it. You're uniquely skilled to do this type of work. Your instincts are priceless. And you should remind yourself that if you're having that instinctual thought, pretty sure you're probably right. And that you should be encouraged to take on the challenge of leadership, especially at a time of crisis, because through that, You may find that that helps you to grow through the experience, to grow in your professional abilities as well. Um, we grow through going through difficult things, and this would be yet another opportunity for that. I want to thank the Michigan Academy for supporting, presenting this material, and to have the opportunity to share my experience with you. It's obviously a difficult piece of material to discuss, but I feel it's a set of knowledge that needs to become part of the family physician's knowledge set, such that, again, they have a place to go to get started. And I hope that this is simply um, a first step in providing family physicians with more resources and formal opportunities to think about what this process may look like for them and help them to move through it in the healthiest way possible. I'm sure that if you have feedback on this, and Carlene may speak to it more, that I could be reached through the Academy, and I would be happy, to the degree I can, to assist others individually and share more on an individual basis if any of the membership broadly have interest. Thank you so much.
Dr. Clamo, on behalf of MAFP, thank you for sharing your story with us. We really appreciate it, and I'm sure it will be helpful, and the resources you shared will help other members really understand the process and just the time frames that you worked through over the last 14 months. To conclude, I would request that if you have a question, please email it to info@mafp.com, and we'd be happy to connect you with Dr. Clamo or help provide additional resources. And for other member events, please visit us at mafp.com, and we look forward to having you join us for another session. Thank you again. Have a great day.